Hello. All is well?
All is well.
Yes, ma'am. Life is an interesting thing, isn't it? You know, and you mustn't be closed.
Some more interesting than others.
You mustn't be closed.
No.
You know, you must open your mind. You must be wise like Saliman, as my wife would say. So this is the big one.
Yes,
yeah,
that was.
It's not fixed.
Big news
Try
today.
try this one here. I'm wondering if mine is bad now. How does mine sound? Let me talk, Aka.
Yeah, so that was big news today.
But I hear, what's that buzz? Oh, it's still not fixed. You can sit there. Yeah, let's see how it works. Let me hear it first. This is what we do. We do technical stuff on the radio. So you'll have a chat with the big G. Okay? So this is the big thing. April 11th, Parliament to end. I know someone's birthday is on April 11th. By the way, I want to say before we go further, condolences to Fred Hazelwood and Rick and Marnie and family for the passing of their wonderful Bonnie. So, you know, what can you say? It's that time, you know. It's that time. You know, we all go through it. It's a scary thing. Is it a scary thing?
What?
Death.
It seems so.
It seems so. Why is her mic low? Is it low or is she just talking low? Okay, she has a gentle voice. It's such an inevitability, right?
Right.
But it's like, you know, trillions of people have died.
Right, but I think death is a process like birth is a process. And
Yeah,
to
but
watch that process.
Yeah, but birth is a little bit more positive.
No, of course it's positive, and luckily you don't have a memory of it.
Yeah.
But I don't think people prepare for death and what that's like.
Yeah, we're going to swing you around to another mic. And it's sad because that should have been dealt with. People aren't prepared for it.
Yeah.
Well, you know, I think we don't know. You're in your 40s, right? Or
Yes.
30s, right? So the thing is, I think that it's kind of like it's a delayed thing for
right,
you.
you don't
You're
want
not
to
thinking of it.
No, not yet.
But I think that I'm thinking of it.
Right.
When I hear people who have died and they're 58,
Yeah.
which is my age.
Yeah, that's super young though.
That's super young?
Yes, 58
in
is
what world?
young.
In dog years?
No, 58 is young.
Well, I'm gonna let you go to young, but I have to say that you need to take super out of that. Okay, super young is like 30.
Well, people live to be 90 and.
Yeah, but they're rare.
Yeah,
that's not common. But so it's a thing, and it's a thing for two reasons. One, obviously, the loss of the person who you loved, and that tends to be a little it's moment. It's just huge. It's a huge thing to know that someone who you know, because love is a weird kind of emotion that links. This is why people kill and all that. It links you to someone in a way that you can't even explain. And so when you lose that being,
yeah, it's traumatic.
It's traumatic.
Yeah.
But also, I think it's also when you're, because let's face it, people die every day.
Yeah.
And you don't think about it. But when it's close, all of a sudden you get kind of reminded. Oh, that's right. That's happening.
And it gives a certain amount of perspective. You start thinking.
I don't know. Well, I just have this thing. I know it's very negative, very, very dire. But I just think that I'm running out of time, Erica. I'm sorry. I'm sorry to throw that on you on a Monday.
But, you know, Ed, I think you're making good use of your time here.
Well, I have made good use of my time. Let's put it that way. You and Kendrick have been doing nothing.
No, apparently not. I need to change that.
You got to hang with me. All right. So, also, so the election. Well, so the election has to happen within 21 days minimum and 28 days maximum.
Correct.
Okay.
Yeah. Or so 30 days or something.
Okay,
like
give
that.
or take it too.
Yeah.
So that means that if it's 11th, that by May 11th.
Correct.
It has to happen. Okay.
Will you be here?
I will, but if I wasn't here, I'd be close by and I'd fly in.
Okay.
Yeah, I'd fly in, even if it was for the day to fly in, I'd fly in and then do what I have to do and go.
So, Ed, what I was wondering, I cannot recall ever being given advanced notice that the House was going to be dissolved.
Well, so I was talking to someone about that, and they said Mr. Ingram did it.
Really?
Yeah. I mean, I don't recall,
that.
but I think
I would have been.
we have to research it.
I remember, you're a reporter in the newsroom, and you get the call, and you dash down to Rawson Square. Exactly. So
we can research it and find out.
Yeah.
But someone did that. It was brought up because I thought that, and someone said that they had done it before. I mean, you remember now, it's only happening like 5 times in our life.
Yeah,
so
no, that's
it's only
true.
happened. So the fact that it happened 5 years ago or 10 years ago, it's not like this is a weekly thing,
right?
That we would recall.
But
so
I like that though.
Yeah, because now it's going to force people to.
I think that's good for democracy.
It's almost like setting a date.
I mean, so what? Just take the next step. Let's
go and
have
register.
A set date.
Yep, and go register. But
Yes.
let's take the next step. It will eliminate so many things.
And I don't understand why it's so secretive. I guess it's the incumbent, the government sort of trying to control things. I mean, I don't get why it's such a big deal.
Well, I'm going to look up what's happening in Britain. I'm going to do that for the next show. But I think what it does is there must be a flip side in the Westminster system of not setting a date simply because you can have it before the set date. In other words, that's the latest date.
Right, that you can do
but
it.
you can call an election anytime.
Right.
Which is also kind of like tweaky.
Yeah.
But yeah.
I mean,
so
that's
yeah,
a certain level of control, right?
Well, they control it because they figure, well, they can manipulate it. If things are getting rough, we can call it early. It has nothing to do with us.
Right.
That's the main thing. It's all about to do with them.
Right.
But it's kind of antiquated.
I agree.
I think let's move into the 21st century with our thing. So you got that going on. Edison Key says he's back with the PLP. Do you ever see Gomer Pyle?
Yes.
Surprise! 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 If you show up to a rally or a thing, people kind of know that.
I like how they said on the news that he was displaying the PLP hand gesture.
Oh boy!
I thought that was funny.
They had the march. It appears it wasn't as big a turnout as before, but I think people are ready to just act now.
Yeah, I think people. I'm happy to hear it's going to be sooner than later.
Yeah.
The election, it'll be good to get it done.
Yeah.
Yeah,
I see the thing in the thing. They must forget, as a dangerous fella. You saw this is about Edison Key.
Oh yeah.
Yeah.
Yeah, the cartoon.
So we'll see what happens. Let's hope for calm. That's what we can hope for. We've always had generally.
Yeah, it's always been
elections.
calm. I'm always surprised at how calm it is the day, like during the day of the vote.
I mean, there's people driving.
It
gets a little animated when the results are called.
Right.
Whoever wins goes out, hits the streets.
Yeah.
And starts blowing their horns.
But generally speaking, it's very peaceful and no violence.
So it's it's going to be interesting. Now this is an analytical thing. And I will make this is as close to a prediction as I will make because I think predictions are a waste of time. The telltale thing, this is about math. I'm trying to be really mathematical about this. The telltale thing will be when the DNA has their first rally, how many people show up. I am going to go on record as saying that depending on that, you will be able to make a kind of a prediction as to who's going to win the election.
All right. So remind me, what kind of support? I know what kind of support they had at the polls, the DNA.
13,000.
Right. Mm-hmm. So what were their rallies like?
I think they had vibrant rallies.
Yeah?
Yeah, I think they had vibrant rallies. We're at the stage now with 30 days out where you're going to have two types of rallies. You're going to have what you call your regional rallies, like rallies in Pinewood Gardens and Montague and Seagrape.
Right.
So it's like areas, right?
Right.
Then you're going to have your kind of national R.M. Bailey, Clifford Park type rallies, okay? The DNA would never have a rally at Clifford Park or R.M. Bailey because they wouldn't be able to fill it. But they did have a rally, I think it was a night or 2 nights before, at Arawak Key. And it's going to be interesting to see. Like I say, it's a night now where people are starting to measure rallies, the two larger parties, in the tens of thousands. Not tens of thousands, but thousands. So, 5 to 10,000 kind of numbers. Clifford Park is a big place.
Well, during the 2012 campaign period, remember the PLP in Clifford Park?
Yeah.
I mean, massive.
Oh yeah, massive. Freeport, same thing. Yeah.
Massive crowds.
So we're going to take a break. We'll be right back, and we'll talk some more of this political stuff. Okie dokie, we're back on this Monday, the 3rd of April. Had any April Fool's action?
No.
It's not a good day for April Fools.
No.
Saturday is not a good day.
No.
You got to be around people, and
I have to say, it doesn't feel like a Monday to me.
It doesn't?
No.
Okay. Maybe that's because Candy isn't here. She couldn't make it today.
Maybe. But
well, why doesn't it feel like Monday?
Maybe because I don't know, it was a good day.
Normally Mondays aren't good days?
No, not really. I'm not a big Monday fan.
Yeah, the thing is that Mondays are unpredictable. You don't know what's coming at you. I had some things to do today, which created some anxiety for me on the weekend because it was just issues. The thing happened, there was no need to have the anxiety. I know I talk about this repeatedly, but I'm really trying to get to this state of things not impacting me.
That's hard, though.
It's hard because I think, and I go back to this thing again, like, do you have a hobby?
Yeah.
What is that?
Running.
Oh, okay. Well, that's kind of energetic. That's
reading. That's not energetic.
That's 2 hours. I don't like 2 hours. Next thing you'll tell me arithmetic. But I think I don't have any hobbies. I said this before, right?
Yeah, you need something.
Work is my hobby, and that's not good. So I have to. I have a date.
But don't you play golf? But you don't play it recreationally. It's business.
No, I don't play. That's out of the question. I hate that. I played golf maybe 2 times this year.
Oh.
I don't play. I put a date on myself. I have managed to. This is the Ed self-help moment.
Okay.
That everyone gets to listen to. I've managed to clear away a lot of things, and I've set a date when I'm going to start my rejuvenation.
Okay.
And that's what I'm going to do.
Is it coming soon?
It's coming soon.
Okay.
Oh yeah. I know it sounds very cinematic. Inner world. But that's a guy who does that, Inner World. Did you know
watching movies can be a hobby.
Well, I do that.
Okay.
But
you want something a little bit more constructive?
It's a little bit not interactive, so I want to have a lifestyle change. I want to feel good.
Okay. So
I know it sounds like a song.
What would make you feel good?
I think I need to be in shape.
Okay.
I think that's what I feel that being in shape is what I need to do now.
Good. Well, that's good
before
to
I
identify that.
What's that?
It's good that you've identified that.
So that's kind of what I want to do. I don't know what's stopping me. There's nothing stopping me really. And I know now this is going to sound really weird. I think I need to dehumanize some people or people. I think what happened. No, let me rephrase that. I need to dehumanize situations.
Okay.
Because what happens is everything becomes a very personalized, linked to my psyche thing.
Okay, so you have to stop taking things so personal.
It's not, and it's not like I'm defensive. I'm talking about like let's say Ken wanted me to bring him some water, okay, and I forgot to bring the water. I'll feel really bad about that. Whereas I just go, I'm sorry, I forgot about the water. Do you understand what I'm saying? It's not the end of the world.
I do right. Okay, so you're a worrier, but I mean, you should feel bad, but you shouldn't beat yourself up. No, I shouldn't feel bad. I should just feel I didn't do the thing, and next time I'll do it. Right. Just say sorry and guess what? And move on.
But because nothing's going to happen bad.
Right. Let it go.
If Ken was dehydrating and I was the only source of water and he would die, that's a different area. But the fact that he just wants some water, didn't get the water.
Sorry about that.
Yeah. And there's and my job, and a lot of people don't know what I do, but my job deals with the human dynamic. Mm-hmm. This is solely what I do. Dealing with the human dynamic.
And that's tough. That's super
because I
true.
can't say it in IRCA terms. Human beings can be IRCA'd up. So.
A little problematic.
Well, you know what it is it's selfishness, and I don't mean selfishness in the sense that it's like an insidious, malicious, selfish. It's just a survival thing.
Mm-hmm.
They want what they want because they think they need what they want in order to survive.
Right.
And so the other person's want is secondary.
Well, I mean, everybody's coming at it from their own perspective,
Right.
and you need a certain amount of consciousness to act otherwise.
And it's very difficult to spend a life. And listen, hey, as you're driving, listening to the Ed Fields self-help moment, don't feel sorry for me. There are many people on a daily basis. Almost everyone is involved in that dynamic. If you're a parent, you're involved in that dynamic.
Absolutely.
Okay, and the question is how do you function without taking that on? Like, okay, we have an issue.
Mm-hmm.
We're going to solve the issue or not solve the issue, but it's not a panic.
Right.
There are some panic things,
Right, yeah.
but
Not everything
fact
is
that-
a panic.
we don't have the 36 box Crayolas. We only have the 14 box. This is not.
Yes. No, I know this is not the end of the world. This is not meltdown time. But you know what? You have to let people get over it.
What's that? Well, that's the thing. Yeah.
Right. Whatever their meltdown button is,
Right.
you have to say, listen, I'm sorry, but this is not going to happen.
No. It's and you move on, and then I mean, I guess with kids and they start screaming and stuff, but so be it. They scream. What can you do?
But
So
adults have meltdowns too.
yeah, we all have meltdowns, and I think that the biggest way to I think being this is like with time thing that Candy talks about, but I just think being conscious of stuff.
Mm-hmm.
So we go through life, and I think about this in a whole realm or range of things that we do we're kind of on autopilot.
Mm-hmm.
Okay, and so like I tell you, you get up every morning and you do the same routine, and then all of a sudden you thought, well, why am I actually brushing my teeth this way, or am I whatever? I mean, it sounds trite, but you're in this mode. You're in a rut.
Right.
That's what you are.
And you
You're in a
don't
rut.
question. You're not questioning.
You're not questioning authority. Not authority.
No,
You're not
but
questioning the way people do things. Why
Right.
can't it be done another way? And so I think once you recognize that this is something, but then, I also have this kind of antithesis toward, and I know I'm saying it, self-help
Right.
guru type thing.
Right.
That's one of the reasons I don't read, by the way.
Right. Well, there are other things to read besides self-help. But
Well,
anyway,
like
that's
what,
another
Barney
show.
Miller? But you know what I'm saying, right? It's always about a new way. And then you know what's sad? Then someone discredits the new way.
Yeah, I think deep down inside, you know what you need to do.
Why? Let me ask you this question, because you're a big reader. And I want to acquaint this to cosmetics, okay?
Okay.
They will get on TV, and they will tell you that if you get this lotion that they got from the back of the sea lion, that it will definitely take out those chicken claws or whatever the heck they call them.
crow's feet.
Whatever. Yeah.
Right,
See, I don't even know what it is. The thing, okay, the crow's feet
Right.
from your eyes or whatever.
Right.
And you think to yourself, why am I buying into this? Because this would be the last product ever sold if it did that.
Right.
You see what I'm saying? If it actually did that,
Right. They wouldn't.
we can
need
move on to another problem now.
They wouldn't need to advertise it.
Right.
Really.
But we fall for this stuff over and over and over again.
Right, because we're looking for
Right.
something to fill a void.
So do I feel, am I being cynical when I hear about the self-help where someone comes along with a new thing?
Yeah, whether it's grit or habit or I know there's a whole range of things.
The whole range of things. They have seminars that people go to.
Yep.
And I'm thinking, because when I go to those, you know what I think? Boy, this guy's making a lot of money. That's the only thing I ever think about when I see those things. Okay. Does that ever occur to you?
Right. Yes, of course.
But then
But
why do
I-
you sit there if you?
But I mean, I don't do the self-help thing,
Yeah. Okay.
right? So I've never been to a seminar. I don't know. But I know.
You go to Tony Robbins?
No, never. I mean,
Every
I
time
know
I think
who
of
he
him, I
is.
think of 86 colors
Yeah.
or flavors.
I don't trust it. I
Ken
don't
just,
buy into
Ken
it.
just got that.
I don't buy into it.
Yeah, but do you? So you don't go?
No,
No,
I've never
okay,
been.
all right.
I don't read self-help.
Okay.
I mean, I just
Yeah, it's because the people who are doing self-help books, they're self-helping. You see what I'm saying?
Yes.
They're self-helping by selling you the book. So I kind of stay away from those things. I guess at the end of the day, look, I know this sounds very basic, folks, and I'm putting it down to you. And it also, and by the way, our guest today is going to be Dr. Thomas McGowan, who is going to talk about cancer and the prevalence of cancer in this country, which is a real thing. This isn't about self-help, although I'm sure there are things you can do to try to prevent it, and certainly things you can do to treat it. Is at the end of the day, I think we're here for a basic reason, and that is to replicate the species. It's a basic reason. And I suppose this is where religion comes in, because it kind of lends, for some of us, meaning.
right.
Because
Give some
there is
order.
really a lot of void as to what it's all about.
Yes.
It's a big void.
And you're going down.
This is some deep stuff.
You're going down a dark road.
Why do you think it's dark?
Why are we here?
No, yeah. But I mean, it's. I told you why we're here, to procreate. It's what are we doing during the time we're
right,
procreating?
in between,
Yeah,
right?
yeah.
What are we doing in between?
Yeah, well, we survive. You see, the thing is, now this is where it's interesting, and I'll just leave it at this, is how we've taken something that is as basic as procreation and replication of the species and survival and flipped that into Maybelline. So
Yeah, I think we should leave that right there.
but you know what I'm saying.
I hear you.
All right. Well, listen, our guest is going to be the good doctor, Thomas McGowan, and I'm looking forward to this discussion. We don't often have, the sciences, and this is a big problem in this country. Cancer. In fact, I was at a function, One Eleuthera, by the way, which is another great organization that we'll have to talk. We had Sean on before, where I didn't realize that Eleuthera has apparently a very high prevalence of cancer,
Yeah.
both prostate and breast cancer.
Yeah. I had heard that, although, I mean, wasn't there some suggestion that it could have been environmental? I mean, I don't know
Yeah.
how true that
I-
was, but they were trying to think of why.
Yeah, well,
there
one
was
of the
such a
things I'm going to
prevalence.
ask Dr. McGowan about is I think I know the reason. I'm not a scientist. I think it's called gene pool.
Yeah.
So because everyone who I know read related.
Yeah, they're right.
Okay.
The gene pool is a little too
See how
familiar.
deep I went?
You're right.
Basic. Everyone who I know read related. So I think so. It's a lot of carries, and and it's a lot of people, and so the gene pool has the same genes.
Yep. And that's what happens.
So I'll
when
ask him
it's-
about
when it's
that.
When it's a small
Well, gene pool, right? But a very high prevalence, and there it's so high that one Eleuthera and perhaps Dr. McGowan will know about this. And the Rotaries are building a cancer facility for Well, I'm not sure for treatment, but certainly for testing.
Okay.
From a regional perspective,
Oh, okay.
so they don't have to come to Nassau, and hopefully there can be some research. But I've got to believe with this high prevalence that we have here in breast cancer, where you have whole families and young and stage 4. What do we call it? Stage 4. There's got to be some. I don't know if it's environmental, but I'm not a scientist. I just believe it's a gene pool.
Yeah, no. I mean, I think in the case of breast cancer, I think they've determined that that's
It's a
huge
gene.
contributor.
Yeah.
That it's the gene pool.
So we got to mix it up. So I volunteer.
Okay, good.
Ken, you volunteer? Help. Let's dilute that gene pool
Well, I think I've done my part. I
No,
know
you haven't done
I
it.
didn't marry into my family.
into Long Island. to the LIA, the Long Island Association?
No.
Anyway, listen, we're going to take a break. We got the news coming up, and our guest is going to be Dr. Thomas McGowan, and this is going to be a very interesting conversation. We'll be right back. Good evening, ladies and gentlemen. Ed Fields here along with Erica Wells-Cox, and Ken Williams is on our board. We're going to talk with Dr. Tom McGowan in a couple of minutes. But right now, I just want to talk just for 2 or 3 minutes, Erica, about Carnival.
Yep.
Postponed. But before you came, Ken and I, we did some research. There's a new date going to be set.
Okay, what's the date?
I'm not in a position to say that.
Oh, okay.
Because
All
that would be, it would be, what do you call it? It was an off-the-record conversation.
Oh, okay. So I have a question.
You can have many questions.
Wouldn't they have done a significant amount of marketing?
Well, somewhat, having been close to the scenario, there is still, anyone who was coming in, that screwed them over because they had made travel plans, et cetera, et cetera.
Right, that was my
The only
first
thing I
thought.
could say is they did such a poor job of marketing. I don't know how many people did get in that trap. So, because for the first 2 years, and I tell you, I was on the commission.
Right.
The intent was completely, let's just say, distorted because of a lot of interference, a lot of just bad moves in terms of really bringing people into the country to take part. So you had some people come in, but it wasn't to the extent that it should have been.
Right.
What is really concerning, and I understand there is a new date, would have been the people who have done all the preparation locally, the bands, the groups who would have prepared for this.
And isn't this announcement coming like the day after?
Yeah, it shows it shows what you call like the top shelf organization, or coordination, or something with Asian in it.
Right.
Okay, so it's going to be, and the thing is, the what you call the main event, Road Fever, really is the cheapest part. I'm telling you, I know this from being there. That is the cheapest, or most inexpensive and less costly portion of the whole thing.
Right.
The government can pull off Road Fever probably for under $300,000 because all of the stuff is the groups.
Right, because it was supposed to be the end of this month in Freeport and the very beginning of
Music
next
Masters,
month, right?
Yeah.
And so they hadn't booked acts.
Yeah,
or
they had.
anything?
They announced it. Marshall Montana.
And so now they're just gonna.
Yeah. So I get and those acts might be available. Hey, listen.
And it might end up costing more money to rebook them.
Hey, as they say, it ain't got nothing to do with me. But I'm sure that the Road Fever people were very upset because.
Yeah, but, Ed, it's our money.
Well, it is. I'm just saying. The thing is, first of all, it's probably going to be cheaper than previous years, but Road Fever is not a big cost to the government. The big issue is these contracts and stuff that may have been signed.
Right.
Who knows? It's a cacophony of all kinds of stuff. Chaos, there, a sea of C. Anyway, speaking of chaos, and I don't know why I'm saying that. There's only another C involved, and that's our subject. Our guest this afternoon is Dr. Tom McGowan, who is with the Cancer Center.
Cancer Center Bahamas.
Cancer Center Bahamas. They're on Collins Avenue. And first of all, welcome.
Thank you.
Thank you for coming by. It just so happened that right after we started talking, Dr. McGowan, that I went to this thing the other day, and I learned of yet another plight, so to speak, and that is apparently in Eleuthera. I didn't know this before. There's this enormous concentration of cancer, both prostate and breast cancer. I don't know about other forms. So I wasn't even aware of that. I knew we had a high prevalence of breast cancer and prostate cancer in the Bahamas, but I didn't know that Eleuthera was like a hot spot. Were you aware of that?
Well, not specifically about Eleuthera, but there is an issue around saying whether or not there's a high incidence of cancer. There's two things. One is there are real incidents of cancer, and the second is how much do people talk about it. So it could be in Eleuthera that in that population, people have become more comfortable talking about. There may have been a handful of people that talked about their own experience, made other people more comfortable with it. Because I do know my experience here in New Providence is that men in particular, do not like to discuss prostate cancer.
Okay.
They do not like to discuss the idea that they're going to get their prostate examined. So there's that aspect of it, that there may be some issue with respect to how comfortable people are discussing it. But I was listening to you before I came in, and it's very true that there's a very high incidence of a breast cancer gene in the population that increases the risk of women getting breast cancer younger. And when it comes younger, it's often more aggressive. There was a study that was done locally and with the help of Canada, actually. And what it showed was that of the women with breast cancer in the Bahamas, 23% are carrying the breast cancer gene, which is probably the highest rate in the world. The clinic I had in Toronto, was at Mount Sinai Hospital. I had a big Jewish population. There's a 13% incidence there, which is a very high incidence.
What is it normally?
A couple percent overall. So it's very prevalent. And the other thing you talked about was familiar relationships in Eleuthera. If there's the gene is present there, it very well, and I'm just speculating.
Yeah.
The gene would be present there, and there may be a higher incidence of it because there is a handful of families that have it, and they're located there. But certainly we see this across the entire country.
Well, if you look at the Bahamas, and I mean, I don't know how familiar we become with the Bahamas, but if you go from island to island, literally there are the mere fact that the Russells come from Abaco and the Pindus come from Spanish Wells and the so and so comes from Andros. I mean, you're not getting a lot of outside intrusion into the gene pool.
Right.
Now, this is an ignorant question, but I get to ask those ignorant questions.
Right.
When you have intrusion or outside folks coming into the gene pool, it doesn't eliminate the presence of that gene, does it? Or I mean, does it literally? And I'm being really flippant. Does it dilute that gene?
No, it doesn't. It doesn't dilute it. It brings in a population that will likely have a lower incidence of it, so that the average incidence is probably going to be lower. But that only happens if the population is starting to grow. So, in the sense in the population, overall the rate may go down a little, but this isn't something that happened since 1960. This has been something that's going on for a long time. And it takes a long time for population genetics to change. I mean, the Jewish population has, all across, Europe, North America, Middle East, and there's this high incidence there. And there's been a lot of, mixing. And so it doesn't go away quickly. There's a population in Quebec, in Ontario, in Canada, that has a high incidence of it as well. So it does take a long time. The big thing is to be aware of it.
Well, speaking into awareness, and Erica, please jump in anytime. I'm of the opinion that when I was 8, I'm just picking a random
a number you can
number of when I was a baby, when I was a small kid.
I can barely remember being 8.
I just subtracted 50.
All right.
There must have been a prevalence or presence of this issue, but that people just saw, well, she's just sick.
Right. So there's a couple things. And first, people became embarrassed. It was a disease people didn't talk about.
Right.
They didn't want to talk about it. We see patients where they've had it for a long time, and they don't want to tell their family about it, and they don't want to get it. They don't get it treated. So
what is the basis of that? I mean,
are they afraid of the treatment itself?
There's denial is a very, very strong thing, and if you have a small lump, at first people are terrified it's cancer. Then they believe, well, that can't be. And then they just ignore it. Then it gets bigger. Then it opens. And then it just progresses. And they just they get used to it. It's just something they have that. And sometimes these, cancer can sometimes grow very slowly. So you'll have someone that have a large mass. They'll have had it for 3 or 4 years. And so that's not the idea people have, that something like this could be growing for 3 or 4 years, but it can. But, if people that have cavities, bad teeth, They don't want to go to the dentist until their tooth breaks.
Yeah.
You know, I mean, until you're forced to go,
Yeah.
people will just
Except that,
hide
you
it.
know, with all the awareness nowadays, and although we were talking about when I was 8, with all the awareness nowadays, I kind of realize that my tooth isn't going to kill me. You know, but whereas breast cancer, you know, the result is not, you know, getting a tooth pulled.
Which makes it for a lot of people scarier to face, right? I mean, people, if you're facing your own mortality, the longer you can put that out,
Yeah.
the better. I mean,
Even though, and again, this comes to education and awareness, even though there is a high degree of survivability
yes,
as a result of treatment, I would have thought that when I was 8, let's go to the 8 reference again, the survivability might have been very low.
all right. Well, let's talk about something that's a little more personal to you and me.
Okay.
It was the prostate.
Okay.
Right. So, I mean, it's one thing for men to say, well, why doesn't a woman with breast cancer get it treated?
Right.
But men with prostate cancer, you get it when you get it diagnosed early, cure rates are 98%, very, very high.
I'm actually like, because you know the question I'm going to ask you in a couple of minutes, but I'm going to let you finish it.
So it's 98%.
Yeah.
But to get to that point where it's diagnosed early, it's before you have symptoms. And in fact, symptoms, urinary problems, are not necessarily related to the cancer. They're just benign symptoms.
Yeah.
And so to get to that point, they have to go to see their doctor. They have to have a rectal exam. And you say that, and men wince. They don't want to. They don't want to go, and so they don't do it. And then it gets to the point where they've got bad symptoms, and they present then when they can't avoid it anymore, and then it's a more advanced cancer. So in people's minds, prostate cancer kills a lot of people. And in fact, if it was screened early and treated early, and in fact, we can sometimes get someone with an early stage prostate cancer. We don't even need to treat them. We just follow them. We just need to know about it. But the problem with it is that sometimes these treatments that are going to give you a 98% cure rate can cause impotence and cause incontinence. And those are things men just like, look at your, it's too bad there's not a TV here. You can look at your face. No.
When you say incontinence, that isn't anything to do with like North America or anything like that.
No.
Okay.
Right. So, I mean, that I think that said it all, right? I mean, would you, who voluntarily goes for that?
You know,
right? Who voluntarily goes for that? So that's really the dilemma, is that, if I catch it early and they tell me I have cancer, what do I do? Do I get it treated? And then, did I need to get it treated?
Yeah.
And then I have no symptoms.
Which goes into a whole nother gamut of things, because, obviously we're more concerned about continence and potence as opposed to death,
Right.
So that's kind of weird as well. But I guess I guess maybe it equates to the same thing with women with breast cancer,
right,
about their femininity and all that
image.
Sort of thing. Right.
Women that they think, oh, I'm going to lose my breast.
But that's changed dramatically over the last several years, hasn't it?
I think it has.
Yeah.
And what about like access to health care? Like the cost, I think, is also a big issue for a lot of people.
It is a big issue.
Yeah.
It's a big issue, and as a Canadian, I've worked and trained and practiced under a public healthcare system where, as a doctor, I mean, everybody came through the door. They were treated exactly the same. There was no issue. There's no extra billing. There's no charges. They pay, hospitals charge an arm and leg for parking, but you don't charge for hospital services.
Right.
So that's been an education for me personally, coming and working in an environment where you have a mix of public and private patients and insurance companies and copay and what can someone pay and can they afford to go for the screening tests? If you have to have a PSA and an examination, that costs something. It's a low rate of picking it up. So affordability, it can be a real issue, and it's a barrier for some people, especially if they feel, I'm fine. Why should I go pay a couple $100 when I feel perfectly fine? And I paid a couple $100, I still feel perfectly fine, and I'm still fine. So
now,
I
it's
understand expensive treatment.
Do you? Because I want to get into some kind of stuff that I was even talking to Erica about a couple months ago. So obviously, the kind of cancer that people generally hear you talk about, or not you, but one talks about, at least in this environment, is breast cancer, prostate cancer. But there's a whole range of stuff going on. Are those the two most prevalent forms of cancer, or are there other forms that are equally as prevalent?
Well, I think breast and prostate cancer are discussed for two reasons. One, breast cancer because there's a higher incidence of the gene. So there's a real genetic increased risk of breast cancer. So that's something that needs to be well known, and people do know it, but they need to act on it. Prostate cancer because there is not a widespread public screening program. So you see more people presenting with higher stage and more aggressive prostate cancers than I'd seen in Canada. So those two, there's a good reason why they're being discussed. The other one that I think is an important one to talk about is cervix cancer, because cervix cancer is a disease that really should be very uncommon as an advanced disease, because there's the vaccine, Gardasil, which decreases the risk of HPV infections and progressing to cancer. It's a big contributor to cancer. And the second is Pap screening, Pap testing, and then to have the Pap test done and then to be able to act on it. And when you catch cells that have just started to change, they're not even cancerous, they're precancerous. And when you remove them, do you decrease the risk of cervix cancer? Man,
You get the cancer in your mind.
I do. But that's an important one because that's a public health intervention that can eradicate that disease. In my department in Toronto, where we had a population of 1.6 million people we served, we saw maybe 10 or 12 advanced cervix cancer cases a year. And we're seeing more than that here in a population that's a quarter.
Is it you're saying more than 10?
Oh yeah, many more. And I want to talk about lung cancer for a second, because a good news story here is the low rate of cigarette smoking. For whatever reason, cigarette smoking just never became a thing.
It's not a big thing.
It's not a big thing. I don't see people smoking, and except the tourists, and I don't see lung cancer. I see a handful of lung cancer cases a year, and my experience was that it accounted for 40% of my practice. And lung cancer kills people. It's a very hard disease to treat. So that's a good news story.
Yeah,
so it's not
it
all
also takes the secondhand smoke and all that kind of stuff.
So it's not all bad news here. This lifestyle of not smoking has really is very, very positive. Then there's the ones that have the same risk as anywhere else in the world, which is rectal cancer, lymphomas, all of those other ones. But I think breast, prostate, and cervix have an increased risk. Lung cancer is much lower risk, and then everything else is pretty much the same.
There's a lot of information out there, especially when it comes, you're talking about getting, screening and cervical cancer. And I keep on hearing, you should get a Pap smear every year, or no, it's okay, you can get it every 2 years. What would your advice be?
Well, as soon as a girl becomes sexually active, she should really start getting Pap smears. And then it depends. So the frequency of Pap smears depends, a little bit on the age. So you get it yearly when you're younger, and then it depends on what the Pap smear is showing. Right. If the cells are completely normal, then you'll get recommendations from the gynecologist as to what. So there isn't quite as simple as a set screening interval. It does depend a little bit on what the results are. Right. But the HPV vaccine is an important one. And I know there's, I don't know about it here, but I know because I work in the Southern Caribbean as well. And I know in some places there's the view that taking the HPV vaccine is like parents giving their daughters permission to have sex.
Yeah.
But it's not. It's a cancer vaccine.
Yeah.
Right.
And you get, you can get cancer, cervical cancer, head and neck cancer. It's contributing to a lot of different cancers, but it's a cancer vaccine. And the fact is, at some point in people's lives, they have sex. It happens.
We're going to take a break. We'll talk about the ignorance quotient, and I don't mean like stupid, but just not being aware. We'll be right back. Anyway, it's the thing they tell you, like if you have an erection for more than 4 hours, call a doctor. Oh. Yeah, that's priapus. Okay, we're here with Dr. Tom McGowan. I don't know if we just came in on priapus. It's a kind of a weird thing. You're driving along and we're hearing about 4-hour erections. We're here with Dr. Thomas McGowan, who is at the Cancer Center of the Bahamas, and we're talking about cancer. It's, the C word. I mean, it actually had that phraseology. And I know even as a kid growing up, I just feared it. I feared it. Any little bump or anything, I always feared it. But I want to talk just for a second more about prostate cancer.
Sure.
I would say at least 2 prostate exams a year. By the way, first of all, is that enough? Should he get them more? Can something grow in between? What's the deal?
If you're completely asymptomatic, there's nothing abnormal, your PSA is normal, you don't really need it more than once a year. So,
okay.
But if you've got
once a week, I should calm down on that.
Yeah, that's starting to edge into something else.
Okay,
So.
I just want to make sure. Sometimes you're like, okay, when they checked it today, well, the growth was happening the next day. Okay,
right. Yeah.
What's the matter, Erica? Okay, if I start walking in there with my own gloves.
Yeah.
Okay.
Yeah,
so
okay.
so the discussion I had with you, and I've had this discussion with others and never really got a clear answer, is that you hear the statement that says if you are, and they always say this, by the way, a black male, that if you live long enough, you will have prostate cancer. First of all, is that relegated only to black males?
No.
Okay, so
not.
Let's take that out of the picture. Yeah. Male, because you have a prostate. And so you say, okay, I've gotten to 75. I'm not kind of hanging out with the honeys. Okay?
Well, why not?
Well, I'm not. So,
all right.
And I'm not 75.
All right.
It's my hypothetical. You don't get to. You don't get to.
I hope that's not my 75.
And you say, well, I don't want to have prostate cancer, so let me just have them remove my prostate. What's wrong with that scenario?
Well, there's a few things wrong with it. One is that
knowing that there's a 100% chance you'll get prostate cancer.
Right, but there's a difference between getting a prostate cancer and getting a clinically significant prostate cancer.
Okay.
So having a few cells that when you biopsy them, you look at them under the microscope and they look like cancer cells is one thing. But if those cells never progress, they never grow, they never extend beyond the prostate, they never cause your symptoms, then who cares? That's just the way they look. So when people talk about getting prostate cancer in 100% of people, a lot of them are clinically insignificant. And in fact, that specific issue was the reason why there was so many problems with prostate cancer screening in the U.S. And why they stopped actually funding prostate cancer screening in the U.S. is because they'd find these clinically irrelevant prostate cancers. Urologists would take them out. Men wouldn't be able to get an erection anymore. They'd be incontinent, and they didn't need to have it taken out. So because people didn't actually know how to treat clinically insignificant prostate cancer, they stopped trying to diagnose it.
Let me ask you just a side question.
Sure.
So what makes prostate cancer different that you can have some cancer cells that are not going to grow? Because all of the other cancers that I know about, when you see that little inkling of cancer, you got to be afraid because now it could grow. So why is prostate different?
Well, first off, we don't necessarily know that.
Okay.
Because the prostate can be biopsied and we can get the cells out and we can look at it, we can see those cells. Now, if you have something, the intestines are very long. Someone's not going to section it completely at the time of an autopsy, and they're not going to biopsy the entire thing. But it's really just the genetics of the cancer. And the point about that is that cancer is not a single thing. I talked about lung cancer earlier. Lung cancer is very aggressive. You get it, you are probably going to die really quickly. Prostate cancer is much slower. It can be. In fact, some prostate cancers can be aggressive. So it's the fact that cancer is not a single thing. Some cancers are aggressive, some cancers are unaggressive. In some cases, diabetes is a much worse thing to get than some forms of cancer.
I'm going to ask a really dumb question here.
All right.
Going on the fact that as we get more and more advanced and we discover new things,
yes.
Are we just lumping a lot of things into one thing called cancer when they could be just a completely different thing? So the prostate cancer might not be quote unquote cancer, it's a different thing.
Well, I think the general public does, but in the medical community we don't. I mean, we recognize that cancers all need to be individualized, and even within different cancers, you have very different outcomes. That's what this whole area of targeted therapies are.
So it wasn't a dumb question then?
No, it's actually a good question.
Uh-huh.
It was a good question, it's part of what the evolution of the understanding of management of cancer is. It's gone from 100 plus years ago, where the idea was cut it out and you're probably okay, to the idea that, well, we need to understand some cancers, they start locally and they slowly spread out. If you have a cancer of the larynx, that's the way it's going to spread. Some breast cancers could be a very small breast cancer, but depending on the way it looks under the microscope, its grade, the involvement of lymph nodes, and some of these other markers, we might know that there's a very high risk it's going to show up in the bones, even though it's very tiny.
Okay.
So it's not all one disease, but it does. They all do have the same characteristic, which is that the cells, these are your cells, don't forget.
It's a mutation.
It's a mutation, and they take on a characteristic which these cells don't normally have.
So they attack the organ.
They attack the organ, they grow uncontrollably. And there are some benign tumors, but you can have a tumor in the brain, which is a benign tumor. It's not going to spread anywhere. But because there's not a lot of space in there, you start filling it up with a lump, it can be lethal.
Yeah.
But it's not going to spread somewhere. So you can't look at them all as one. And I think that's part of what people's fear is. They think, I've got cancer. Oh, my God, my aunt had it, and she lived for a year. But it might be a man with a clinically insignificant prostate cancer. It might be a woman with a very, very early stage cervix cancer. Do a little, remove it, and cure rates are very high.
Where are we in terms of treatment of cancer? So back in the 60s, when I was 8, to hear the word cancer was... It was like, okay, well, it was nice knowing you. It seems that we've made tremendous advances
In some, yes.
in the treatment of some, like you say, lethal lung cancer is still very lethal. Things like pancreatic cancer, things like that. Where are we? I suppose percentage-wise, if that's, I don't even know if that makes sense. I don't even know why I said it, but I'm going to use it because it's the only metric I could use now. Where are we percentage-wise in terms of the capacity to treat the range of cancers that exist?
Well, we're right now, I would say, going through, there's been a series of sea changes that have occurred in the management of cancer. One was the advent of, modern surgery, where you could cut things out and not kill people by doing it. And then the introduction of, basic chemotherapies and the more advanced chemotherapies. And there was a time in the 60s where it looked like chemotherapy was going to be a cure-all because there were some lymphomas and diseases that chemotherapy worked very, very well for, and they saw cures they'd never seen before. We went through a period and then the big understanding was the characterization of the disease. Do we understand how does this cancer start, where does it spread, and what are the areas that are most at risk? And then we start to learn how to target the treatments at those areas. So it's not so much that the treatments have improved in that setting. What's happened is we understand where it's going to be, so we go there to try to treat that.
The application of the treatment.
Application. Then the thing that is the most important thing to remember is that the highest cure rates are when the cancer's caught the earliest. So screening programs and catching cancers earlier has a huge impact on survival rates. So even if we didn't change what we did, if we didn't learn anything more about cancer, if we just moved all the patients that we've diagnosed down from one stage,
right,
we'd improve cure rates dramatically.
Well, see, now you talk about health care, right? So,
yes.
For instance, breast cancer, you have the mammogram and, basically self-examination. Prostate, you have a way to check that out. Cervical, you have the pap smear. But then you have these cancers that can be anywhere, like in your knee or something, that, you just don't know it's there, right?
Right.
Without a scan. And so you go to the health facilities and you say, okay, I'd like to have a scan. And a scan is, and by the way, I'm doing this because I did it. The scan is $1,000, okay?
Okay.
The insurance doesn't cover that.
Well, no kidding.
And the question I'm saying
it's
is,
not necessary.
well, but this is the question I want to ask. I asked the doctor at the time, what is the rationale behind getting a scan? And he said, well, if you took 100 people, for one person it would be a big deal.
Right.
So the question I'm asking in terms of money spent is you take 100 people and you spend $100,000, that's $100,000. But one person's treatment who didn't catch it could be millions. Why wouldn't they then?
Well, first off, I would doubt it's 1%.
Okay.
The catch rate is much, much lower than that.
Okay.
So I wouldn't say it's 1%.
Okay. All right.
You really do have to look at the economics of it and make that decision. For instance, we make these decisions all the time. I mean, you could eliminate car accidents if you buried every single road. That's a cost
Or you
can't
didn't drive.
do. Right, but so we those
Yeah.
types of decisions about what's the cost compared
Right.
to what the benefit is, and just doing a random scan to pick something up doesn't work very often. We do know that when we do staging investigations for patients, we'll sometimes randomly pick up a kidney cancer. That happens, not very often, but it does happen. And that's kind of akin to what you're talking about, which is to do a scan without there being any signs or symptoms. You're better to do screening tests in a population where you know there's a higher chance of them having it. The other problem with these scans is that they're not 100% perfect. So you get a false sense of security when you're told it's negative. And also there's the false positive rate. If the false positive rate is higher than the true positive rate, you then have sent someone for a biopsy.
And the treatment.
So I had a patient, and this really drove it home for me. I had a patient who insisted on getting a scan because she was afraid she had cancer in her spine. And she had no symptoms that would have suggested it.
It was just in her mind.
Yeah, so she went to Buffalo, we're in Toronto, and you can pay for the scans there. She had it. And it said, oh, you might have a deposit in your spine. So, but it wasn't something to be biopsied. They said, come back in 6 months, and they scanned it again. It still might be. And then eventually, 2 years later, they came to the conclusion that she didn't have it. So this woman who had no symptoms spent money. The false positive rate was higher than the true positive rate. And she spent 2 years thinking she had a few years to live.
Yeah, the stress of that.
Right. So, it's more than just, it doesn't always do good.
Okay.
And also there's an incidence, we know that if we do too many CT
Then
scans,
you get radiation.
increased risk of lung cancer.
Right. So how then does one, you say early detection is important,
Yes.
except for, well, we're going to take a break. We'll take a break. We'll come back. I was going to say, except for these tests that you can take in the office, like the pap smears and et cetera, how do you detect these other, I would say, exotic cancers that can happen, but they're out there. So we'll be right back. We'll talk about it. Ed Fields here, along with Erica Wells-Cox, and Kendrick Williams is on our board. And we try. You're driving home, folks, and it can be a long drive. Hopefully, believe it or not, hopefully this type of information, in a kind of a weird way, makes the drive a lot shorter because we're trying to give you information, and so hopefully you're listening to this. And so I want to talk about colon cancer. You also mentioned male breast cancer.
Right.
And also want to talk about treatments. How do we determine between quackery and what's real? And this new immuno treatment thing that I feel very excited about, but it might be, a hoax, but you'll tell us whether it is or not. And then also, of course, I want you to mention your center down the road. So tell us about colon cancer.
So, colon cancer is an important cancer. It's a common cancer. It's no more or less common here than it is, anywhere in Canada or the U.S., but it still is relatively common. And it's something that if it's caught early enough, cure rates are very high. Surgery is curative. Sometimes people need to get chemotherapy, but the cure rates are very high. And the way it's you can do a couple of things. One is you can have a colonoscopy, which is a big test. The other thing you can do is to check for what's called fecal occult blood, which is if there's traces of blood in your stool, we can test for it and test for this trace amount of blood because there shouldn't be any blood in it. It's not blood that you see, so you can't just look down and say, I don't see any, so it's fine. And that screens. And if you have that, then you need to go for a colonoscopy. So it's a way to not do a colonoscopy on everybody. It's certainly a way to screen people that may not have the resources to go and pay for colonoscopy. If you don't want a colonoscopy, there's actually another test called a virtual colonoscopy, which is
I've had that one.
a CT scan. I can see you're excited. You pulled your headphones right out.
I was raising my hand.
Yeah.
But that's a gassy one.
Yeah. But yeah, it's true. You really have to expand your gut. But and you don't want to be around you afterwards. But the thing is that it's a way to scan your colon using a CT scan, a high precision CT scan, and we can actually do that here. And it allows you to pick up small lesions in the colon without. And you do have to do a little bit more frequent than a colonoscopy because it needs to be a little bit larger to be picked up, so the interval between them is shorter. But it's a good alternative between a colonoscopy and just doing the fecal occult blood or putting your head in the sand.
And then, of course, and then we're going to talk male breast cancer.
Right. So the thing about male breast cancer is that it does occur. And people just say, well, how can it can? Men have breasts and, they can get cancer. The thing is that men really don't get breast cancer unless they're carrying the gene. So if anybody has a male relative that has breast cancer, then that family likely has the gene. And men, if they feel a lump in the breast, they should get it checked out because it can be breast cancer. The thing is that the cure rates are very high. It's the same cure rates as for women, and because there's less tissue, you can catch it smaller and treat it. And so you're checking yourself. You're checking yourself.
I don't want to put one of these to a mammogram.
It's treated exactly the same way. It's treated exactly the same way: surgery, radiation, chemotherapy, depending on the extent. And I've treated men with breast cancer, and cure rates are high. But it's important to know that men can get it, and that if they have it, their family carries the gene, and they really got to look into it.
Treatment. Now, first of all, I suppose the question to ask, if there's, for relevance sake, is what is the scope or the capacity here in terms of treatment? And I'm sure obviously it leads into the fact that you have a cancer center, but what is the overall capacity here in terms of cancer treatment?
Well, that's a good question. The capacity here is excellent. I moved here from Canada 2.5 years ago, and the quality of the physicians that I'm working with is excellent. And one of the things that's really surprised me a lot since I got here is how many people feel they need to go to the U.S. to get better treatment, and it's just wrong. It's just not true. You don't need to go. I was talking about the breast cancer gene here. The Americans don't have the same experience with black women having the high incidence of the breast cancer gene. In fact, I had a patient who came from a family that was gene positive. She saw an American doctor, and the American said, and she asked about testing. She said, "Oh, don't worry about it. You're not at high risk," because he's extrapolating from his experience in the U.S. It's not the same population. So to be treated at home by doctors that understand the specifics of the population, the genetics.
Because a lot of research has been done here on it.
Yes, there's been some very good research done here by physicians from here. And so, when you look at how do you get good treatment, number one, you have to have good doctors that can make the right decisions. You have to have the ability to carry it out. You need to have the nurses and support staff that understand how to deal with you. And the other thing that's hugely important for recovery from cancer is being around family and friends.
The support group.
Sitting in a hotel room isolated is very, very difficult. And, getting back, and I will mention our center, I'm a radiation oncologist. I'm a cancer specialist that treats with radiation. And we recently had the American College of Radiation Oncology visit us and do an accreditation, and we got a 3-year accreditation, which is the most they give, which is really a stamp that the quality of care and the quality of radiation is as good as you can get anywhere. In my opinion, I think it's better, but that's
your
that's
opinion.
what I'm going to say. But at the very least, we know from the accreditation body that we meet all international standards.
Okay.
And so traveling for care to me is a detriment. You fragment your care, you're away from your friends and family, and you're being treated by physicians that really aren't familiar with the population.
Right. Talk about, and I know I'm not getting the phraseology correct, but I've been watching a lot and researching a lot this new sort of immuno treatment where they send in diseases. They extrapolate cells from like smallpox and other things, and they attack the cancer cells. And they seem to be, from what I've seen, some really, miraculous results.
Well, there's a whole branch. When we give standard chemotherapy, it's what's referred to as cytotoxic therapy. The drug kills cells, and we use it and we exploit the difference between the ability of the normal cells and the cancer cells to recover from the damage. Normal cells recover better, but it kills the cells. What you're talking about is a whole area of targeted therapy, where we're not using the same mechanism where we're trying to kill cells. We're trying to target the cells that are at risk. Immunotherapy is very, very old. There's a we've used immunotherapy in the treatment of superficial bladder cancer. You instill what's referred to as BCG in attenuated virus into the bladder, and it causes immune reaction. It kills off these early stage bladder cancers. What's the real exciting part now is targeted therapy, and there's an absolute explosion of these. And you have to have specialized testing, and you do need to send this off. But because you need to send the cells off to get this testing done elsewhere, it doesn't mean the patient needs to go with their cells. Mm-hmm. The patient can stay here and get the drugs here. But the miraculous thing about these is that if you can identify one of these targets, then you can give a drug that matches this, that hits this target. You can improve cure rates and improve outcomes dramatically. We've seen differences in how melanomas respond. The classic one that a lot of people have heard about is Herceptin with breast cancer. There's a gene HER2/neu. That's an old gene, but it's targeted therapy. Patients that had this gene prior to the introduction of Herceptin had a worse cancer and had a worse outcome. Now, if they have this gene and they get Herceptin, they actually have a better outcome than the average breast cancer patient. So this is the exciting part, where we're getting inside the cell, seeing where the mutation is, and being able to target. And the oncologists that are here, they're very skilled at understanding this.
And go ahead, Eric. No, sorry.
Are all cancer patients eligible for that sort of targeted therapy?
No, really, you have to have the gene,
right?
Mm-hmm.
But also it depends on the type of cancer.
Right. So what I saw were things like some leukemias, some brain tumors, right. and the part that I found interesting is, and I want to talk, if we have some time, just real briefly about it, is that these treatments were kind of like a one-time treatment. Yeah. That rather than prolonged treatment, they put in this drug or whatever it is, the virus, and while you felt pretty bad for a couple of days or so, it just wiped it out. The question is this where you see the cures going? And here's where I get the little cynicism, because there's always the business of these things. And when you look at, just to make an analysis, say, look at renewable energy versus fossil fuel energy, right. That, their whole empire is set up on fossil fuel energy versus renewables. And to kind of change that paradigm is a big transition. Right. Is there going to be resistance to this, or is this something that will easily be evolved to?
In my opinion, it'll be easily be evolved to, because when there's something that improves cancer outcomes, oncologists embrace it. Okay. The barrier is going to be cost. Okay. Some of these drugs are very, very expensive. Older chemotherapies might have been $7,000 for a cycle, for a course of chemotherapy. Newer targeted agents could be $5,000, $6,000, $10,000 a month. So there's a cost issue, and that's really where it's going to be the adoption of these interventions is going to be driven by cost, I think, more than anything else. But as far as there being anyone that would not introduce a treatment, I mean, just even from the simple perspective, if I'm the one that's curing cancer, I'm going to have more patients coming to see me. So
yeah.
And also, I mean, that conspiracy theory.
I got to throw it out there. But let me ask you. So Joe Biden is been, they said, the moonshot for cancer.
Right.
Where do you see cancer treatment going? And just let's pick a number out of the hat over the next 20 years.
Well, I would say what I think is going to be a sea change. I talked about earlier the fact that one of the big advances was that we understood how a cancer, where it started, where it first spread to, and what was the risk of it going elsewhere in the body, and we targeted those. When we did that, we did it sort of generically. We know that a breast cancer with a positive lymph node, in general, all of those patients should be treated a similar way. Where we're going is I believe, personalized medicine. So we're going to be able to say, breast cancers in general have this pattern. You, as an individual, have this other pattern, and we're going to treat you in that way. And I think our understanding of the genes, it may not necessarily change the modalities that we use. It may not change the drugs. It may not change and the drugs will change because they always do, but the drugs or the radiation or the surgery, but it'll change how we target it at individual patients. We'll no longer be treating, because let's say we have a cancer where if you don't treat it, 60% of people are cured. If you do treat it, 80% are cured, for example. That means that 80% didn't need the treatment.
Right.
The 20% that aren't going to be cured regardless, and the 60% that were going to be cured without it. So I think we're going to be able to parse out that 20% that are going to benefit from the treatment, and we'll be able to say, listen, you're one of those unfortunate that our treatment doesn't work. We have to do something else. You're fortunately part of the 60% where you don't need further radiation, you don't need further surgery, you don't need further chemotherapy. It looks on the surface like you have a bad cancer, but you're one of these that doesn't need anything further. Right now, we treat all 100 of them. And I think where we're going to go is that, and we're getting better and better at it. That's what targeted therapy is about. We're getting better and better at this, and I think we're going to be able to find out who that 20% is that's going to benefit, and the 60% that don't need it, and the 20% that aren't going to benefit anyway, which I think would be a miracle.
You know, when I think of death, because I think of that, there seems to be, for the human being, 3 or 4 major causes of the problem. Yeah, it's a problem. You know, death is a big problem.
Yeah. Yeah. All right.
Heart attack,
Okay.
stroke, cancer.
Right.
You know, you got a broken leg. It's a broken, accidents. Yeah, accidents. And I would, and I don't know where. I don't know where accidents fit on the list of causes of death. It's probably fairly high.
Yeah, especially in a younger population.
Okay. If we get to where, you know, cancer, because that's a big one, right?
Yeah.
And certainly a debilitating one. I mean, a heart attack, it's, you know, boom. A stroke, it's, you know. If we get to the point where, you know, cancers are cured, what does that mean? I mean, isn't that kind of, do we live, I mean, how long do you know, what happens next?
I don't know.
You know, you're the doctor. You're supposed to know. You got to tell us this stuff.
We'll live to 150.
Yeah.
I don't know. But the thing is that we may not actually cure the cancers, but we may turn them into chronic diseases. Like think about AIDS.
Like diabetes.
Right,
Yeah,
like
yeah,
HIV.
yeah, yeah.
Think of HIV. I mean, that was something that you had it. You were
Dead.
quickly, but now you're not. Diabetes is never cured. Treatment of diabetes is a palliative treatment because you do not cure diabetes, but people live a long time with it. So, and prostate cancer, you know, in some cases is becoming a chronic disease. You know, so people have it. I have patients that I've, you know, started treating 15 years ago, and I was still treating them when I left Canada. So, you know, there's what you want is you want to be alive, healthy as you can be given your age, and that's it. And whether or not you have some high blood pressure, diabetes, maybe some irrelevant cancer that you're taking a drug for. I mean, I think it's going to become something where we're not afraid of anymore.
You see that on the short, medium, long-term horizon.
Well, for some, it's in the near term. I mean, prostate cancer is becoming more like a chronic disease for many patients. And that's something I counsel people about a lot. So and as I said right at the beginning, it's not all one disease. So for some of them, yes, they're going to become chronic diseases. For others, we're really, the only way we're going to get on top of it is to stop it, like cervix cancer.
Yeah.
Cervix
Or
cancer.
don't smoke.
Yeah, don't smoke. I mean, I wish we could take what you have here about not smoking and move it to Canada. But cervix cancer can be gone. And that's how we're going to deal with that.
Okay.
Gardasil and screening and early interventions, cure rates will be very high.
Well, Dr. McGowan, it's time for us to go. But I'll tell you before, you know, there are a lot of subjects that you want to, you know, when we do this show, and you go like, okay, how long can the conversation last on that? The reality is this lasted a while, the whole time, and it could go on for a lot more. I'm hoping that people, you know, the layperson has just a better understanding of the realities.
Right.
Because fear is drives a lot of, you know, because it drives as much of getting treatment
Yes.
as opposed to not getting treatment.
Right.
And so hopefully we would have taken a little bit of the fear out. And your center is on Collins Avenue.
Yep, 72 Collins Avenue.
Is that by the Heart Center?
That is at the Heart Center.
Okay, so you got the Heart and the Cancer Center, two major courses.
Phone numbers 502-9610.
Okay.
The other thing I just take away is that people that are cured from cancer, you don't know who they are. They don't stand out. So, that you only see the people and you hear about the people that aren't cured. The people that are cured, living a good life, you don't see them. You don't hear about them. And there are a lot of them.
Okay.
There are a lot of them.
Well, that's good to know.
Yeah.
Well, thank you, Erica. It's been a plaisir,
Thank you.
as we say in Quebec, plaisir. Ken, always a pleasure. Thank you very much, Dr. McGowan. We'll see you on Monday. Rogan will be back, and who knows what we'll be talking about yet. I'm sure with what's going on now, a lot of the politics will be permeating the whole airwave thing. All right, we'll see you. Thanks a lot for listening.